آدم أستاذ النفرولوجي في جامعة اسكندرية. Give us a talk on dilemma of proteinuria after kidney transplant. اتفضل يا فندم.
Thank you very much, Mr. Chairman. شغالين طيب عشان الدكتورة سامت مصلحتي. It is my pleasure to be here وأنا أشكر أستاذي الدكتور ماهر فؤاد and give me this opportunity to share with you this very prestigious transplantations meeting, which actually has a very excellent program. I wonder if we can do something like in the coming 1.5 months. I will spend the first 10 slides to actually, I was looking for the junior to see, because I'm trying to push them to submit abstract or cases, and I extended the time till the end of January to get their contribution. This is my talk about dilemma of proteinuria after kidney transplantation, and the proteinuria is a sign, maybe without cure, however, with rather effective treatment, predicted prognosis and outcome, whether or not you treat or not, and still with mystery more than clarity. This is in 5 to 8 of March this year, inshallah ta'ala. The junior can precipitate in many aspects in the website, and just to push them to try to submit cases or abstract, just because a specific committee from the Egyptian Society Board and the organizing committee will look to this, and 100 registered accommodation already sponsored by the Egyptian Society to attend the conference. And just a list of the foreign international speakers. We have, alhamdulillah, we got the accreditation of the ICN and the EDTA, and we applied for the European Committee, and we have 11 confirmed, inshallah ta'ala, foreign speaker, includes Ramuzzi, Fugu, Johnson, Glassok, Jadou, Bergman, Sayed, Nahas, Kawali Firmike, Kanu, and maybe, and this lady from Greece, and maybe Lanier and Pierre Ronco. And the program is started usually by plenary, ending by CBC, and has got 16 scientific sessions with a kidney forum and clinical pathological conference, and every of these sessions has got a moderator. And the agenda of the talk. Which proteinuria we're speaking about? Is it really important? And the spectrum in our patients, and what called the slow and high-grade proteinuria after transplantation? Why is proteinuria associated with reduced patient and graft survival? Does proteinuria vanish post-transplantation? And drug-induced proteinuria and the take-home message. Just a telegraphic things which I would like to press. Proteinuria is not many microalbuminuria, and maybe a maker or a marker, and has got a relation to cardiovascular and renal risk, and it is maybe a continuum. And the proteomic, although I will not touch it yet, it is important to differentiate between proteinuria and microalbuminuria. Just to how to measure it. Of course, the urine protein creatinine ratio is more or less equivalent to 24-hour, our gold standard of measuring the proteinuria, but I must emphasize that urinary protein creatinine ratio is not the urine albumin creatinine ratio. They are different. What about the toxic effect of proteinuria? Just in a hurry, it can cause glomerulosclerosis in remnant kidney model. It is associated with tubular interstitial damage of massive proteinuria, and this can cause glomerulonephritis and implicated in diabetic nephropathy and hypertension. And the renal expression of pro-inflammatory genes in rats, in overloaded animals, this is in KI95 by Eddie from UK, activation of NF-kappa B in the tubular cell by proteinuria, transdifferentiation of the tubular cells of remnant kidney, and the proteinuria induces tubular cell apoptosis and tubular discontinuation, glomerulotubular disconnection by proteinuria, other mechanism. And there is a lot of damage related to tubular interstitial damage due massive proteinuria. And the fatty acids can be bound to albumin in the KI 2002, The complement also is related to this proteinuric urine and complement accumulation associated with tubular site of protein. And the C5b9 in remnant kidney is related to the toxic effect of proteinuria. And in a remnant kidney of a model, there is a deficient of the C6 in this model due to proteinuria. And this is an EM of this same picture. Not only that, but the protein overload promotes loss of differentiated phenotypes of the podocytes. And actually this is important when I will tackle the paper of sirolimus, because they don't find anything of the podocytes later on. TGF-beta gene is upregulated by the podocytes. Podocyte-derived product control mesangial cell is affected by proteinuria. We got the impression that the angiotensin is related to prevention of proteinuria, but actually proteinuria is related to angiotensin 2, of course. And this can cause interstitial infiltrates, occurs as a proximity of the protein overloaded tubules, and this can activate the RAS system. The blockade of the local RAS leads to enhanced tubular degradation of proteins, and the classical view of the renin-angiotensin system, as you all know. This tubular RAS is actually upregulated in the tubule, so the glomerular proteinuria can cause damage by tubular interstitial through the RAS system. And a local renin-angiotensin is incriminated in this, and the tubular ACE expression is stimulated in proteinuric mice, and also the ACE inhibitor attenuate this. This induction can be blocked by the 81 blockers. The NF-kappa B, as I mentioned, important signal modulator. The albumin by itself stimulates chemokines in cultural proximal tubular cells. And the ACE inhibition attenuates these activations. And angiotensin 2 can be incriminated in all of these. So the cascade is proteinuria can cause tubular uptake of proteins, and this causes local increase in angiotensin 2, incriminated in F-kappa B and TGF-beta as a toxic effect of proteinuria. Does isolate proteinuria induce fibrosis as well as tubular damage, tubular injury, and that's actually seen? Some of this work done by our group long time ago, 11 years, in hypertension, and we proved that in salt-sensitive rat, the production of superoxide as functional regulation of angiotensin 2 related to proteinuria, and this is published in Hypertension. But there is important things to mention, that there is a link between the kidney and the micro and macro, and a link between the cardiovascular and the micro and macro also. Just to see the difference between Hong Kong, and they got tram also and a lot of tall building, but they are clean and very disciplined, not like us. Going to the clinical part of the lecture, because the first part is about the toxic, the importance of molecular biology of proteinuria. What are the causes and consequences of proteinuria following kidney transplant? This is a paper coming from Minnesota, showing, of course, that proteinuria is a common following kidney transplantation, affects more than 40% of kidney transplant in the first year. In general, the level of proteinuria may be as low as less than 500 and more than 1.5. And that's why it is a very vital, important to detect proteinuria following transplantation. As you see, the prevalence, maybe more of our patient is less than 150, but still there is more than 1,500 in the first year. It is related to the body mass index also. If it is increased and in aged population, the proteinuria is much important. What are the causes of post-transplant proteinuria during this first year? Of course, as you know, there is a residual proteinuria from donated kidney, but this I will tackle in a minute, because there is a paper antagonizing this concept. Glomerular disease of the graft, either recurrent glomerular disease, other, or effect of HLA class 2 antibodies. Interstitial fibrosis, an effect of mTOR inhibitor, and I tackle this in the end, an important functional discrepancy between the graft and the recipient needs. Dr. Fatina will have a lecture about FGS, but I just want to emphasize that the most common is not FSGS, it is membranoproliferative type 2, which is 80% recurrence in the graft, but the graft loss is only 30%. The FSGS, actually the disaster is 50% loss of the graft after recurrence. This is different than the other list. It is the factors related to increased proteinuria present. As you see, has got a similar, but there is donor-related factors as older age, female, lower renal function prior to transplantation, and the recipient, the male, and the high weight. Just see the difference. The female as a donor and the male as a recipient, and just maybe a statistical bias. What is the importance of knowing proteinuria in our transplantation patient? This is because it can cause graft loss. And actually, if it increases more than 1500, the graft loss will be increased maybe after 60 months. But if it is less, it may be till about 120 months. It also related to the patient survival. The same graft, if it is more than 1500, it will be increased death. But if it is less than 150, it may be till 120 months. This is to another side of the coin, to see if there is a resolution of proteinuria of the native kidney origin following live donor renal transplantation coming from the American Journal of Transplantation 2005. And to assess this, they got 14 life-related transplant recipients, some preemptive and some on dialysis. And they got the urine protein creatinine ratio more than 0.5, and they transplant this patient and show that immunosuppression consists of TAC, MMF, and steroids. Antihypertensive that might induce proteinuria were avoided, and the serum creatinine was 8, dropped to 1 after transplantation, and the pre-transplant urine protein 0.5 to 9 and dropped to less than 0.2. And as you see, of course, the serum creatinine going after transplantation and the GFR by MDRD is increased. As, of course, this is individual part of the, if you see the proteinuria, it decreased coming from the native kidney. And I wonder, to my experience, if the patient on dialysis hasn't got proteinuria much as 2.7, but this category of patient, 7 patient, has 2.7 after transplantation, they coming to 0.14, and the preemptive transplantation, it has got 3.2 urine protein creatinine ratio dropped. And they concluded at the end, after doing this DTBA scan, as you see, this may be from the preemptive transplantation, has got the native kidney, including this DTBA uptake of radioisotope. After transplantation, the uptake is vanished and going to the transplant kidney. So, they conclude at the end that maybe the native kidney after transplantation has no role in producing proteinuria. The last paper which I tackle is about sirolimus as associated heavy proteinuria in a renal transplant patient. And sirolimus is a potent immunosuppressor, and increased proteinuria is associated with sirolimus, but the mechanism may be still debatable. Within 10 days of transplantation of this case study developed severe proteinuria that disappeared completely after substituting the TAC for sirolimus. As you see from this curve, this is the proteinuria after putting the TAC is going down. Although it is a little bit here, how they put the TAC here, and it is going down. I don't know how he interprets that this is related to TAC alone. And the renal biopsy, which is an important thing, if you remember that proteinuria causing the podocytes differentiation, the renal biopsy disclosed a normal glomeruli even without effacement of the podocytes, and using the albumin antibody showed that the glomerular has no role in producing this proteinuria. And this is from the slide that the glomeruli is normal and the problem is the tubule. In conclusion, the live donor renal transplant recipient of this particular paper with immediate graft function and proteinuria of the native kidney origin resolves in the early post-transplant. And after the immediate post-transplant period, proteinuria cannot be attributed to the native kidney, and work-up of proteinuria should focus on the allograft. Because of the time, I just want to give 2 slides about management and therapy. There is a debate when to start and why never to stop, and to retard progression versus to prevent the glomerulopathy or nephropathy from the start. But I must press to treat proteinuria, 3 aspects must be considered in a kidney transplant. The cause of proteinuria, the non-specific reduction of proteinuria, and the reduction of cardiovascular risk. The key concept, the post-transplant proteinuria is a common, could be due to multiple causes. Even low grade, as less than 500, is sensitive indicator of reduced graft survival. The reduction of survival of a graft with proteinuria is probably due to the same problem that causes proteinuria from the start. Therefore, the cause of post-transplant proteinuria must be investigated. Proteinuria, even low grade, associated with patient survival, not only graft survival. And as we said, to treat proteinuria, we have 3 concepts. Mr. Chairman, and I have 3 minutes left, I'm ending by this slide. In absolute terms, aiming for increased graft survival and minimizing late graft loss, at the lecture of Joseph Cambisto yesterday, I believe that proteinuria post-transplant must be diagnosed, investigated, treated, and treatment is associated with its risk factor. Thank you very much.
شكرا أستاذ دكتور أحمد آدم for this very nice talk. questions في الآخر ولا؟ لا عندنا 3 دقايق أهو.
3 دقايق.
ممكن. اتفضل.
دكتور أحمد. استعمال الإيس في الإميديت بوست ترانسبلانت. الأول كانوا مخوفيننا جدا وبعدين شجعونا. قول لي رأيك إيه في الكلام ده؟
رأيي أنا صغير عشان أقول رأيي بس يعني لكن
حضرتك محاضرة يعني.
لا مش قصدي. I believe it is more after 1 month there is no harm whatsoever. هو debate before 1 week yes or no. صراحة my personal opinion before 1 week I'm a little bit reluctant. Also the losartan by specifically some people and maybe some papers using it even prior to renal transplantation for a couple of days. The losartan by name I'm speaking about. But personally, in my personal experience, more than 1 month is one of my choices, but keep on the patient.
طب اشمعنى ايه التوقيت ده جبته منين يعني؟
لا
ليه؟ توقيت مانث ولا اسبوع يعني ايه؟
لا
ايه اللي هيحصل بعد اسبوع ولا مانث؟
لغايه ما ستابيلايزيشن هقول لحضرتك انا اعتقد في ليترشر سبورت اللي هقوله بس يعني مش حاضر لي في نفسي في دماغي. الفكره ان very early period 1 month the graft is liable to a lot of complication. If the patient is stable, creatinine is stable, اما هدخله حاجه ثانيه ممكن اقدر اعرف الحاجه دي ضايقتني ولا ما ضايقتش الجرافت. لكن قبل في اول first week يعني definitely بالنسبه لي no. من 1 week ل 1 month على اساس ان العيان بعد 1 week بيبان الجرافت ممكن very good ولا في delayed graft function ولا whatever. بس انا
فانكشنال وايز.
ايوه.
وطبعا محاضره رائعه جدا وتشالنج. موضوع ان انا اعمل ترانسبلانتيشن والعيان فيه بروتينوريا 3 جرام والكلام ده صعب جدا ان احنا نعمل ترانسبلانتيشن وفيه اكتف بروتينوريا. الحاجه الثانيه استخدام الاس انهبيتورز.
انا معلش انا دي نقطه هي النقطه اللي في البيبر اللي غريبه. ما اعرفش انا اذا كان في حد كلنا بنعمل دايلسيس. انا يعني نادرا ما شفت واحد على دايلسيس وعنده بروتينوريا ماسك. يعني هو جاب 7 منين؟ عشان هو 7 و7 اللي هم عايزين بروتينوريا. لكن لو انت عايز انا هفكر حاجه اتعلمتها من زمان قوي ان انا ازرع لعيانه بروتينوريك. انا هقول لك في يانج ليدي 23 سنه في انجلترا من 20 سنه. انا قلت الراجل الجنة اللي كان بيعلمني هيزرع لها وكرياتين الجام 3 4 وطبعا كانت بروتينوريا. ليه؟ قال لي حاجه غريبه جدا، قال لي البنت المنسس بتاعتها مش ريجولار وامها هتديها لايف ريليتد، فانا عايز الحق اديها كدني عشان الكرياتين ينزل واحد، وانا خبطت القصه كلها عشان تلحق تحمل.
بس الكلام ده انكدوتر ومش عمرنا ما نعتمد يعني 3 كرياتين 3 وهنعملها ترانسبلانتيشن مش ضامن.
طبعا ايوه لا ده
انا
اتفضل عشان مش حاجه ثانيه.
العيان لو بيعمل دياليسيس في الغالب مش هيلاقي بروتينوريا بكميه كبيره.
ايوه
لكن اللي بيحصل لو هو جلوميرولو بس يعني اف اتش اس او ام بي جي ان او ميمبرنس ودخل في انديسيشن ديزيز، العيان مستعجل يعمل ترانسبلانتيشن. احنا اور سكول من بوستبون الترانسبلانتيشن فور 6 مانثس او 1 يير لغايه ما يحصل دامج للبروتينوريا. في الغالب ما بنزرعش، عمرنا ما زرعنا حاجه وفيها نفروتكس.
طيب do we have evidence انك
No,
انت
no evidence.
طيب ما ده الكلام، ما فيش evidence. ما هو انا بقول لحضرتك we don't have evidence that transplantation to a patient with proteinuria وهو indicate whatever indication ايه كرياتين بتاع will harm the. فايده البيبر دي اللي انا فوجئت اني شفتها ان احنا كل الكونسيبت جزء من كده جاي من نايف كدني او نيتيف كدني في اول حاجه في الليسته في اي ليسته، فطلع ان هو الكلام ده ممكن يكون ديبيتابل.
وبعدين ده الريكورنس في منتهى الصعوبه، فهو احنا بنعتمد على الريكورنس وظهور البروتينوريا، لان لو استنيت لما يحصل باثولوجي في الاف اتش اس مثلا يبقى ده انتهت القصه. فوجود البروتينوريا ايرلي دي طبعا ده مشكله، وبعالج ساعتها الريكورنس ما بفكرش في الاس انهبيتور في الايرلي بيريود ديت، انا اكتر ما بفكر اعمل بلازما اكسشينج ولا اعمل ايه ولا كده.
بس معروف الاميلويد والديابيتك والفوكال سيجمنتال بيستيل بروتينويك تيل اند ستيج. عشان انت بتنتقد الراجل ده غالي، احنا ما نعرفش
ايوه المشكله. ايوه هو
مع الثلاث حالات دول بيفضل البروتينوريا موجوده، مش زي الاوريجينال كيدني، مش نورمال كيدني، لكن بيفضل فيه ريزيدوال بروتينوريا ومسف. وفي ناس كتير فوكال سيجمنتال بالذات يبتدي يعمل اند ستيج وهو لسه نفروت.
هو ايش السؤال البروتينوريا لو واحد
باين بعد اذن حضرتك لو العيان sometimes post transplant يبقى بيحصل severe hypertension and all other antihypertensive treatments except ARBs and ACE are not for pulmonary hypertension. انا قريت ان انا ممكن ابدا ACE او ARBs رغم ان هم بيخوفونا منهم even in the first week.
هو ده في دوبلر خلاص، ما دام في دوبلر بطمن باكسكلود الارثروسكلوزس مفيش مشكله.
ما يعني انت عندك تو بارامترز، اكسكلود الاول مفيش اني ستينوتيك ليشن، واني ما دام ما حصلش ارتفاع في الكرياتين مور ذان 30% في الفولو اب يو كان كيب كونتينيو الايس او الاربس. معروف انت بتوقفه لو زاد 30% ايفن في اي واحد تديله علاج.
حضرتك النقطه اللي انت تاكلينج از فيري ديبيتابل. انا مش حاجه في بيبر قبل يومين من الزرع وفي فيرست ويك وفي بقى سيف خالص بعد 1 مانث. ده الراشونال. فكل اللي حضرتك قلته فعلا.
ما هو زنقني وقال لي الضغط ما بيظبطش.
ايوه لا الضغط ما بيظبطش، ده سويه الناس مسكوته بيه.
Thank you very much. Now we